tibiofibular dislocation as well. They're spontaneously reduced as well.
Oh, is that the one we took? Not the one we wrote up, is it?
It's similar, but not completely. But but basically he came in grossly unstable knee, big guy. So I wasn't there initially, but he was.
Okay, so how did he fall? What was his mechanism?
No, he just came out of the car.
Right. Okay.
Yeah. So he twisted.
And what did he dislocate?
So tibiofemoral, and I think patellofemoral as well.
Yeah. Patellofemoral and tibia. Not like the one we had.
No, that one was slightly crazy though.
That's the first one ever in the world described tibiofemoral, patellofemoral, and tibiofibular. Right. Okay. So this is what we're going to talk about. Epidemiology. Any idea of incidence? What's the difference between incidence and prevalence? Yeah.
Incidence is
it's a bit basics.
New
pathology,
cases,
huh?
like kind of new cases, and prevalence is.
No. So incidence is over a period of time per month, usually per year. Prevalence, just remember point prevalence is what it is now. How many are there out there now? Point prevalence, incidence, okay? Mechanisms, classification, assessment, management, definitive management. Right, here's your incidence. 1 to 2 per 100,000 per year. Probably 50% spontaneous review. How would you know? You don't really know, right? But probably 50%. Right, male predominance, vascular injury is about 20%, but again, you need to qualify that with the type of dislocation. Perineal injuries, amputation risk, okay? What we'll do is we can PDF these so that everyone's got them, okay? And these low velocities, so your one, Ernest, I would class as a low velocity, right? Whereas opposed to this,
oh my god.
I'm showing this. Neither of these people died.
They take his head as well.
I'm worried about it.
Okay. So these are high velocity. I'm going to show you an ultra high velocity later, okay?
What's that, a rocket?
So, then you've got sports, okay? And I think the majority are actually sports. Okay, you're just not going to notice a lot of our sports injuries, and Shez will tell you that. You know, you kind of see, okay, all these ligaments are injured. It was probably a knee dislocation. All right. Funnily enough, all he had. What do you think he had? Actually, what do you think he had? PCL, yeah. What else? MCL. He actually just had a MCL. All right. And this guy, obviously, you can see what kind of dislocation is that? Anterior. So you refer to the tibia relative to the femur, is the point, okay? Right. Okay. This is your one. The incidence of this is massively rising. This is not a joke, because I've just done one of these, okay? This is not a joke, because it's ultra low energy. It's what you just said, he was just getting out of a car. Okay?
Actually, he was running away from a drug deal.
Hey, was he?
Yeah, the guy had his knee fused.
Yeah.
Yeah, he was running away from a drug deal, and then he fell over on the way, and the police caught him.
Oh, okay. I didn't know.
It's not they needed to run away, he would have been caught anyway.
Okay? So, when you ask to classify it according to mechanism first. Okay? That's a big, important point. Now, here's your direction of dislocation we've talked about, anterior, medial, posterior, lateral. Which one has the highest incidence of popliteal artery injury? Posterior, obviously. Which one has the highest incidence of perineal nerve injury? Okay? Does that make sense? So when you start, I don't know whether they still do this, right? But I would say, tell me about knee dislocation. We'll start. Incidence, mechanism, classification, mechanism, direction. What's the next classification? Who else knows?
Schenck.
Okay, so there's your Schenck and Watson. 1 ligament, 2 ligaments, 3 ligaments, 4 ligaments, all right? And then with fracture or without. Your cruciate's in the center, the laterals on the side, and you start thinking about which ones are injured, okay? Bicruciate, with or without postlateral. Everyone happy with that? Right, so we have just published or are about to publish the Basque BOA BOAST guidelines. Have they been published already? You heard them? Seen it?
No, I just read that.
How did you
It didn't
read it?
look like it's been published.
It did.
It didn't look. It
So
looked
how
like
did
it
you
was-
read it?
You sent it to us as reading
Oh.
material. People are doing the pre-reading, Mr. Gupta.
Great. So this is important, okay? You've got to state these posts. And I tell you what, you know, when you go through these Delphi protocols, there are 15 to 20 of us, much bigger than, you know, we had actually international people. Stuff, when you get down to this, you think, oh, it's bloody easy, isn't it? You have to get down to this after about 5 hours of discussion, because there's so many things you discount before you get to stuff that looks simple. When it looks simple and it's rememberable, that's when you know you've won. Okay, so when you get to this, it's important. Okay, the CT angiogram. Now, most of us in London, we know that most of us can get CT angios, but in the sticks you can't. But this is now a stipulation. You really must get a CT angio unless you can't. In which case, what do you do?
Yeah.
Okay, right. That's important. The next is this. Keep this in your wallet somewhere, in your digital wallets, okay? This is the configuration, and I didn't know this. This is what the guys have come up with when we've had all this, everyone talking about it. This is the configuration you need so that we can do our multi-ligament reconstructions afterwards. Okay, so what this is a kind of multiplanar monoplanar X-fix, where the pin sights are way away from your tunnel position.
Can I ask a question? It might just not be a scenario, but if you had an unstable dislocation, like you've relocated, but then you've put it in an above knee cast, can't get a CT angio, how are you doing your ABPO?
Why have you put it in an above knee cast?
I don't know, like if it's an unstable thing temporarily,
who wants to have a go at that, sort of addressing that question?
or would you just put it in a cricket pad?
It's all right.
Something
I'm
fine?
glad you asked the question. Abby.
So the question here is that you've got a really unstable knee.
Yeah, so
you
you're trying to
reduced it.
hold it
Yeah.
with a cast.
Okay, so I think I'd probably do a neurovascular assessment before you put it into something that then changes, if that makes sense. So I would do that assessment first. Then, if it's like an open injury, are we talking about closed injury here?
It might just not be a scenario, but
No, it might
So
well be.
the point is, I wouldn't put it in a cast, right? I would put it in a brace, and if it's still subluxing out of a brace, you need to take theatre.
A hinge knee brace, but locked in extension.
What about cricket pad?
Cricket pad, yeah.
yeah.
I mean, one of the first papers that describes knee dislocations, which I think is one of the first papers that we've used for SC3, says the management is for above knee cast, but I guess we've moved on.
We've moved on. It's the whole point why we've redone. When we get to redoing the guidelines, it's because they need to be redone, right? Because all this stuff's come in, like CT angio, right? So there's your X-fix configuration, okay? And this is why going back to the mechanism makes a difference. This is for ultra high energy and high energy injuries, generally sports injury. If you go to a sports center, they say, do not put an X-fix on. It's a disaster. You generally don't for a sports injury. It's not that unstable. It's a medium energy injury, okay? Right, so the next thing is arterial injury. This is important, okay? You might only see one in your career, but when you do, you've got to do the right thing, otherwise the person's going to lose his leg. So we spent a long time on these arterial injury guidelines, okay? To do with shunts, vascular being involved, fasciotomies, what else is there? You know, just again, position of X-fix pins, that kind of thing. So this is what you need to bat out when you go to your vivas. Okay? Right. If there's neurological injury, the ideal is you explore at the same time as when you're doing your reconstruction. The last one I had was an ultra low energy. He had ACL, PCL, posterolateral corner. He went to 3 different hospitals, including Stanmore. The problem was they didn't do these dislocations, so then he went somewhere else, but they didn't do the neurological. So he came to me 2 months later. Okay. So I explored him with one of the Stanmore surgeons. Bad Italian guy, I've Well, we'll call it Matt.
Fucking
Fucking hell, it's him. So you know he did it prone, and then we turned him around to do the rest of it. It's really important. But you know what? Ideally, you want to do it all together. For plastics.
But isn't the traditional teaching to stabilise from a nerve injury point of view, to stabilise the knee first, like the multi-leg,
Sorry.
so that therefore you're exploring the nerve under a more static environment?
Okay, so I think if it's really unstable, you want to stabilise with an X-fix. When you do your definitive multi-leg, in an ideal world, you'd have the nerve surgeons there with you. But that's what we said, where possible. So, you know, those words took ages to get to. Some people are saying, no, it should be must. We're saying, come on, let's be practical. Okay? So, perineal nerve injury, here's some data. Again, when you're asked about it, it depends on the nature of the dislocation, high energy, low energy. Is it complete or not? Because that makes a big difference to prognosis. Male versus female, fibular head neck fracture. Okay? Right, the next thing is, what do we do? When you put your X-fix on, don't just have a go. I mean, it's a thing, right? These guys need, you know what, to be honest, 15 years ago I had a bit of a go. I'll show you one actually, right? Because I did it staged. Beyond that, right? So get it to someone who can do it. And you've got to do an MRI. There's no question of just having a go, doing an open procedure. You need the vascular surgeons, you might need plastic surgeons. Ideally, you want to do it within 3 weeks. And these days, a lot of places, your consultants. Certainly, I used to. Do it myself. No, but you know, it's very reasonable to do consultant operating. It just makes it a lot easier. It's knackering when you're doing more ligaments. And VTE, we'll come back to that. It's really important, okay? So this, you might notice is an ultra high energy, and someone tell me why you think it was an ultra high energy.
Looks like a youngish skinny patient.
Yeah?
The other side is on the other side.
Then amputation. There's an IED. Right? So he blew off the other leg, but this one, I think he must have landed on the knee. So this is ACL, PCL, MCL, and a bit of post-structural. What I wanted to show you here, so he'd already had, an MCL repair, okay, which obviously failed. You don't repair ACL. So this one, what's gone here? LCL, yeah. What's intact?
MCL.
Yeah. This one? These are all mine, by the way. LCL, PCL, post-lateral corner. That was an MCL. I'll come back to intermediate instability. There you go. So you know you've got to get these stress views. I love stress views. Okay, because sometimes the MRI, especially with chronic cases, doesn't tell. So a lot of my patients, I say, look, I'm going to do stress views with you under, and that would really tell me where the opening up is. Plan for everything. Okay, so I do stress views quite regularly, usually intraop, but you can do kneeling stress views if you can get them well in hospital for PCLs. Yeah. Did that.
Sorry, Mr. Gupte, quick question about the stress views.
Yeah.
Isn't your examination with the patient fastly enough for you to make a decision?
You're kind of right, but sometimes it's subtle. And sometimes I'm thinking, is that lateral, is that medial? Because your neutral point, you're not sure about when they've all gone.
Okay.
It's quite good to get an objective measure. When they've all gone, you just don't know where neutral is. So then what's anterior, what's posterior?
We might cover this later, but if you have all 4 ligaments gone, is there a preferred order?
Yeah, do that. So non-operative, in general, if your central struts are stable, the collaterals you can do later. Okay. Minimal instability, significant comorbidities. I'm not sure about ultra low energy. I'll come back to that because more and more I think they need to be reconstructed. Okay. I tell you what, we have had. We need to write up really. At Imperial, we get a lot of obviously high energy. We get a lot of pelvic fractures. So Angus says to me, "You can't do anything with the knee until I've done the pelvis." So then he's done the pelvis, and then they're non-weight bearing. He doesn't really want a great big brace, a great big kind of, stuff. So we've actually left them for a couple of months until the pelvis has been done. And I tell you, probably about 20% have healed. And it's interesting. So, there are times when they heal, but most of the time, and I've got 2 or 3 where I was absolutely blown away at the healing and having completely stable knee.
But the healing of what? The collaterals or the
Everything.
cruciates?
Everything. But that's unusual. The teaching is that you should do it. But it's just with these pelvic fractures, we've had to wait. Right, operative management. In general, certainly 3 or 4 ligaments need operation. Sometimes 2 ligaments need operation. Okay, if you've got an open injury, you've got a vascular injury, you've got a nerve injury. That's clear. That's kind of obvious, really, isn't it? Any questions on indications? Timing is a little bit more nuanced. Again, you've got this kind of 3-week window, but there are times when you have to wait with other injuries or other complications from their injuries. So you get to it when you can, but that one was 5 years old, that IED one. He was a refugee. So he came, actually might have been 10 years. He came 10 years after us. So I got him from the, what are they called? Rehab specialists, because they'd given him a prosthesis on the other side, but he didn't have a stable knee. Sometimes you get these chronic ones, right? Right, the order, sorry, yeah.
So with I remember reading something when I was revising for ST3, and it was saying about if you do arthroscopy in less than 2 weeks, they've got a higher risk of compartment syndrome. Is that?
Yes, if you use a tourniquet especially. Right. I think you've got to be careful, is the answer. You don't want to have your pump pressure up very high. Okay. In general, arthroscopic compartment syndrome resolves if you wait long. But you just don't want your pump pressure up 70 and then just have this. I've had it a couple of times actually. It resolves. Okay. Right, so in terms of order, you want to get your ACL, PCL done, and then you do lateral collaterals. Now, I'll go in order of reconstruction in a minute, okay? You might want to prioritize PCL or post-lateral corner depending on the instability. Fix osteochondral. Now, what do you do first? LCL post-lateral corner next. Do you agree with that? Is that what the sports guys do?
It depends on if it's acute, as in it's bone avulsion or if you're repairing it. But I tend to go for cruciates first, get all tunnels ready, get it drilled. Because then my idea is I was taught was you get the tension correct, the knee to be under the femur. Because then if you fix the collaterals first, potentially, then they're going to be, if their knees off, they'll be slightly off. When you retension it, then only then do you know when it's going to be in front of each other. That's in a single stage scenario.
I agree, and actually the point you made is drill the tunnels before you pass the grafts. So if you pass your ACL, PCL, and you drill your post-lateral corner tunnel, you might go through one of your grafts. So generally, I drill the tunnels, then I pass the graft, and I do ACL, PCL. Okay. Right, so my battery's about to go out. So
There's a charger on the floor, is will that work?
That works, it's a USB-C. Plug in.
So operative versus non-operative. In general now, and this is again where things have changed, things have moved on, there is a tendency to favour operative management. Better functional outcomes, better rehab, better return to sport sometimes. So we are a slightly biased crowd though, aren't we? We're surgeons. If you've got any doubt, KD3 is false, okay? Okay, the key thing is you want to get them moving. You don't want to put them in a rigid brace for more than a couple of weeks. You want to get them moving, okay? You should be confident in your reconstruction to be able to move them. What you do need to do, the key thing is the PCL. Okay, you could get chronic PCL sort of stretching out. So what do we do for the PCL?
Jack brace.
Jack brace. Okay. You want to get some pressure on that tibia. When is it important to have the jack brace on? Say 3 months. When is the tibia subluxing back? When you are
Sleeping.
sleeping. So you put them on. You know, I put them in a jack brace for up to 6 months.
After the,
Post-op,
to
for
protect your
sleeping.
reconstruction.
For sleeping, not for. After 3 months, they're out. Then there's a question of whether you can anticoagulate them or not. You know, really moot point. Okay. But that's what the bracing is for, and maybe the collaterals a bit as well. Not really for the ACL. Okay. Some people say 20 degrees of flexion. I worry about that. Okay. Generally put them on extension. Yes, if you've got PCL, it is a little bit. So this guy came off his moped. Unfortunately, I haven't got his actually, no, that might have been one of the pre-ops I showed you actually. So he's post-op. I think we did a PCL posterolateral corner. You know, this is kind of the function. He's gone back to playing football, but he's not going to play at the same level, right? The kind of function that you get, what you're aiming for. I would say that with PCLs, you want to improve 2 grades. If you've got a grade 3, you probably, if you're being honest, have got a grade 1 post-op. That's okay. It's all right, it's generally okay. All right, so he's got a bit of a grade 1 PCL post-op. ACL solid. LCL is solid. Feels good. That wasn't injured anyway. A little bit of a PCL. It's got a little bit posterior. Okay, this one is about sort of evolution. So this guy, he had an LCL PCL. And some of the teaching 15 years ago was, look, do the posterolateral corner first, because what you're doing is you're getting rid of the coronal and the sagging back. So I actually did his posterolateral corner with the aim of coming back to do his PCL. And you can see, sorry, I've probably trimmed this video too much. His LCL's fine, right? His LCL's great post-op. Okay, well anyway, he had a posterior draw, but he didn't want his PCL done. But now I'd definitely do a PCL. Outcome scores, I think they're slightly over-reported. I think they're not quite as good as we think they are. Okay, but they're not bad. And I think we've got better at doing them. Nerve recovery, I think, as I said, it depends on whether it's partial or complete, and the state of the nerve when you go in. Got to be careful of neurovascular damage during your surgery, particularly around the back. After fibrosis, I think the reoperation rate in these is probably about 30 to 40% to go in to take out hardware, meniscus that hasn't healed. Those are the 2 main things, arthropfibrosis. And I think they get back to a reasonable level of function, but I don't think they're going to have a normal knee. So you can't promise them a normal knee. Say, I don't promise you a normal knee. I'd like to improve you. Return sports rate's variable. And remember, there's an osteoarthritis risk, okay? There aren't great randomized trials. There never have been. Why not? Because it's quite hard. Each of these injuries are so individual. But probably we should have a couple more. Timing of surgery, bracing, no bracing, all those things, okay? Right, so, you want to reduce it, splint it, assess it for neurovascular damage, do the right imaging, understand what's damaged, and decide whether they need an operation or not, and then get it to the right place